Okay, so having said that, I'm going to just present the live case that we're doing. I have Stephanie Wilson, who's our nurse practitioner, and she'll go through the details of the case. And then while I'm working, we can go back to some of the lectures and may hopefully stay on time. Yeah.
All right, so this is an 81-year-old male. He's been following with us in the clinic for his abdominal aortic aneurysm. Other past medical history includes previous smoker, quit 20 years ago, hypertension, and atrial fibrillation. He was seen back in September with the ultrasound that showed his aneurysm to measure 4.5 by 4.4 centimeters. It had been that way for several years. At that time, he was actually considering enrolling in the Nectaro Stable trial. We were working on getting some of the screening done. Next slide. However, he presented to the emergency department yesterday with new onset abdominal pain. It was left-sided. He was tender on exam. A CTA was completed. Next slide. Ooh.
Say that again, Chris. Oh, it's cut off.
I think our feed is just cutting out here.
I think we're having issues with this feed again.
Yeah.
Anyway, the aneurysm. Okay, play that. Let me see if that shows it well. Initially, he was, go back. Can you play that? Continue to play it? Yeah, keep going slow, slow, slow. Here you go. So it's very tortuous. If you look at the 3D reconstruction, the aneurysm now measures 5.1, 5.2. I know we fixed them at 5.5, but his aneurysm grew from September to now from 4.5. 4.5. So there is, and the patient presented with significant tenderness. He was worked up for diverticulitis and other stuff, and so we decided, to fix this. And obviously, you can decide on what, and what we're going to use for this particular case, and we can go into more detail with Ben and Luis, and see which graft, why we use a particular graft. The plan is to use the trio bifurcated stent graft design. I've been using this graft more and more recently, and I've incorporated this particular graft into most of my physician-modified stent grafts. Sometimes we even use the Relay Pro thoracic to extend, higher up. The advantages are significant. One, it has suprarenal fixation. Two, it also has infrarenal fixation. And the most important thing that I like about this is that it comes in significant length sizes. So you can have a short body, long body, and I think most of these cases, the longer body has made this graft more accessible to treating complex abdominal aortic aneurysms, including PMEGs too. In addition to that, it also has a locking stent technology in the limbs, and so there's very less likely chances of a separation and type 3 endoleaks or so. So I'm going to go ahead, and we will then present this case. Go to the next slide. Obviously, it's a relatively low profile compared to most of the other devices. We're going to use a 30 device today, a much longer body. And you can actually go back to the screen, Chris, and we'll just show, we just did an aortogram. Can you play that aortogram? Mm-hmm. The iliacs are extremely tortuous, especially the left one. And so I had to put a sheet to protect that iliac. It's almost like a U. Mm-hmm. And so I put in a long sheet just to protect that iliac so that when you cannulate the gate, we don't have to struggle too much with the direction and the iliac becoming a problem. So this is the case we're going to do. I would suggest you go back to the next paper, and we'll continue working and then present it as soon as we're done.
Sounds good. Thank you, Venki.
Questions I can answer.
All right, we'll continue the presentations. Go ahead.
Yep. Good luck with the case, Venki.
Oh, you go. There we go, guys. Nice talk, Dr. Accarino. So we deployed the Endurant graft, which we thought we would do, because of Dr. Accarino's presentation. But like I said, what we decided to do for that particular case was the trio endograft, and I showed you the features of the trio graft. So we deployed it. The features are really nice. It's got a very good slow deployment system. The markers are very clear. You can adjust for parallax. And then it's got a longer body. So we used a 30-100 body because this left iliac caused us a lot of problems. If you look at it, it's almost like a U like this. And so on the left side, gate cannulation was easy. But putting the limbs, we had to dilate that whole thing. When you have a very tortuous but a big vessel and you put in the stiff Lundquist wire, it makes it extremely difficult because you got like a pseudo, stenosis. Let's play that last angiogram again. No. Show me the final angiogram. So we put it, Like I said, the features are basically a longer body, suprarenal and infrarenal fixation, and a locking mechanism for the limbs here. This should the final angio. Yeah. So that is the deployment system. As you can see, a little strange anatomy on the right side over there. The renal, we had to take different angles to make sure that we were not covering that right renal. The left renal was pretty nice. We deployed the main body. So you can keep the ipsi limb controlled, constrained, and you can see the angulation of that iliac over there. That's why I had to put that long sheet to protect that iliac. It's almost like a complete U of that left iliac here. And there's a tight stenosis at the origin of that common iliac too. So the main body deployment was good, and then we cannulated the gate and then dilated it with two balloons, large balloons, to get the limbs up in there. Shoot the final, let's see. Hold respiration, please. Okay, left renal is good. There is a leak, proximal. I think it's a type 1. So I'm going to go balloon this up. What else can we do? Ben, what do you think?
Yeah,
Previously?
I just balloon it and not even worry about it.
Go
Look, you've got 4 centimeters of seal right there.
Yes,
Looks pretty
yeah.
good.
Go back one.
The one thing I'm more concerned about
back
is
one, go
that
back
tight
one. Yeah.
aortic bifurcation. You know, it
Left
looks to be
iliac.
like around 20
Yeah.
millimeters or so. And in
a
that
little
situation, I
larger
would
than that. Yeah, you're
balloon
right.
both of those
Go back.
Okay,
stop.
limbs pretty aggressively.
Yeah. Yeah, I'm going to balloon both those limbs. I'm going to balloon the proximal neck.
Venki, it's
I don't
Cassie.
know
If
whether
I
to put
can make
this
a
stent.
comment,
Hey,
Venki.
Cassie, what's up? Yeah.
I hate to leave the
Go ahead,
OR with a
go
type 1 endo leak, so this may be a patient
Yeah,
where the
I
endo
agree.
anchor, if you can get rid of it, endo anchor may be a good option for this patient.
Venki,
That's another option. But let me get, yeah.
just
Who's
just balloon and just give it another 30 minutes. Have a cup of coffee because the heparin will be gone and this will seal itself rather than putting
Yeah,
an
I think
endo
that's
anchor
good, yeah.
and creating havoc for the neck.
Yeah, that's what. I'm going to just gently, yeah, my coffee is getting cold to your right. So I'm going to gently balloon this with a quarter balloon, and then we'll take a few views, and I'll show you the final picture again. So go
All
back
right.
to your next case. I think you have one more.
We'll go to the
And
last
then we go
to
from
the
there.
last presentation,
agree.
and we'll come back to you, Venki.
Let's go.
All right. We can hear you.
Korea is not
Hey guys,
available.
I think this session is going to come to an end.
Yep.
So we ballooned this, and we kept it up for almost a minute, and we ballooned distal too. I think there are 2 lumbars there too, but I think the final angio, as you're seeing it playing, shows the graft has landed perfectly. It's a very diseased neck at the level of that left renal, right renal. And I see the leak is actually almost gone completely. So I'm going to stop this. I think with the reversal of heparin, I think this will seal off. And the other thing with Trio, and Ben can attest to this, is there's been a lot of sac shrinkage with the Trio graft, and maybe y'all can discuss why with this particular graft, and then we go from there. But for now, I think I'm fairly pleased. The leak is markedly less, and then with the longer neck, longer body, and good apposition, I think we will leave it, and I will not deploy anchors, at least for now. And we'll take a look at it. Maybe at the next Congress, I can show you some anchors. Thank you, guys. Thanks a lot. Take care.
Thank you very
Thanks,
much.
Ben. Thanks, Lou.